Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning. This is Talking Therapy, another podcast with Marvin Goldfried and his esteemed long-term friend and colleague,
Alan Francis. Hi, Marvin.
Alan Francis. Notice I didn't say old friend.
Well, that would be true too.
That's right. I'd have to do the phraseology in just the right way. Long-term is probably better. Great. So listen, today we're going to continue what we did in our last podcast. You were talking about concepts with it, I don't know if you called it psychoanalytic or psychodynamic or dynamically oriented, but within that general ballpark, concepts that would apply to therapists regardless of orientation. So you covered a few. Would you recap and then extend?
Sure. So I just jotted down 12 different concepts. Not that these are sacred. Other people would come up, or I might come up with a different sorting. And we went through the first 6 last week. Maybe I'll briefly summarize what we said about those first 6, and we can go on to the next 6. The first was a quote from Einstein that everything should be kept as simple as possible, but no simpler. And we said that we distrust, I think we agree on all of these things pretty much, that we distrust people who make things so complex that they sound, impossible for people to understand. And we're against jargon. On the other hand, we're also troubled by people who make things sound so simple that everything is due to a chemical imbalance or everything is due to trauma. That life's complicated, but it's not so complicated that it can't be explained in simple language. The second was that we support the biopsychosocial model that brings all 3 of these important areas of causality and of treatment into focus, that there's biology to most of the problems, there's psychology to most of the problems people come to us with, and there's always a social context in which they're occurring. And that anyone who thinks that everything is biology or everything is psychology or everything is sociology, any reductionism is always wrong. That people are complicated, and we need to take a balanced view of the different forces that are impinging on them.
I think professionals who are parents and have 2 or more children typically acknowledge that there's a certain amount of genetic and biological composition, especially when their kids are vastly different at birth.
The third was that the child is father to the man, that the events early in childhood have a lasting influence on who we become as adults. And
the child is parent to the man.
Right.
It's parent to the person.
Yeah, I was quoting the poem. You were being more politically correct.
Okay.
Thank you for that correction. I needed it. And that related to this, that people form repetitive patterns of behavior, that ways of seeing the world, of interacting with the world, of feeling emotions, that these develop a very strong, powerful impact on people's lives. They do the same things and make the same mistakes over and over again. And that to understand current behavior, current symptoms, it's useful to try to see how these, it's often useful, not always, but often useful to see how these fit into a long-standing pattern of behavior. Then next, the 5th point was that we're only conscious of the tip of the iceberg of our behaviors, that we do a lot of things for reasons that we're not aware of, our motivations. And modern cognitive science has confirmed Freud's intuition about this, and the intuition of authors going back to the ancient Greeks, that human beings are not fully aware of their motivations and why they do what they do, that we make rationalizations for why we feel and do things, but very often we're not aware of the basic underlying causes. And that sometimes understanding the unconscious automatic things we do, that understanding those things in more conscious terms is very helpful, which brought us to the last thing we were discussing as we left, and that is the role of insight in opposition to corrective emotional experience. We said that insight can be very important, that understanding why we do what we do can be very, very helpful, but often it doesn't really change behavior as much as we'd like it to. And that corrective emotional experiences that occur either within the treatment or in real life, and usually it's best that they happen both in the treatment and in real life, in addition to insight and helped by insight, the corrective emotional experience is a major driver of change in people's lives, a major reason why therapy works. And that's where we were when we left.
Well, so far, I am boringly in agreement with everything that you say. And, maybe sometimes boring is good as opposed to proliferation of, or disagreement of everything, every point that you want to make. The language may be different, but that's okay. So far, I'm on board.
And it's really interesting. I think that maybe the most interesting thing in all of these podcasts is that although we both started out from very different basic foundational approaches, had very different types of supervision, began seeing patients in very different contexts and with different approaches. As we matured to learn more, learned from our patients, followed our patients' leads, we came to pretty much be very equivalent as therapists. We have different, sometimes language for what we do.
Yeah.
But my guess is when we're in the room with a patient, we're much more alike than we would have expected to have been 40 years ago.
Good
so that
point.
brings us to the new stuff.
Yeah.
And the seventh item on my list was the role of, and it's kind of related to what we said so far, but everything is related to everything, the role of vicious and virtuous cycles. That people tend to get into vicious, people we see, people who've come to us with problems, tend to get into vicious cycles in which the thing they most fear happening happens partly because they contribute in their behavior, in their expectations, and that self-fulfilling prophecies form, and that people's reactions to the world also force the world to react to them in certain ways, and that we often see people who are experiencing downward cycles where a little bit of depression leads to demoralization about that depression, a little bit of anxiety leads to more withdrawal, and that the initial symptom may be much less of a problem than people's reactions to those symptoms. And that one of the things we want to do is reverse vicious cycles by substituting virtuous cycles. And sometimes very small changes in behavior or in feelings or interpersonal relationships, very tiny beginning changes, sometimes have a cycling effect in the positive direction, reversing what previously had been the negative direction.
Yeah. And certainly people who do couples therapy see this emerging right before their eyes in real time. And even if you don't do couples therapy and you're working with an individual and you're talking about an interpersonal problem where they're complaining that their partner is mean. And why is your partner mean? Well, because when I ask for something, he or she doesn't give it to me and gets annoyed. And I don't understand why. And then it gets uncovered that the person asks in a way that has an angry tone. And the partner is responding to the angry tone, not to a characteristic that they have. So you get the patient to become aware of that, have insight, to use your words, that they're doing that. And then a corrective experience would be to ask in a different way and see what happens and break the vicious cycle. So I think, what orientation is that? That's a good orientation.
And one of the wonderful things about the awareness of the role of vicious and virtuous cycles is that very small things that happen in a session can have enormous impacts outside of the session. That very small things that happen outside the session can have enormous impacts both outside and inside the session.
Yes, yes.
That just saying the right thing at the right time, in the right way, to the right person, heard the right way, tiny changes in behavior then amplify. And sometimes you can see people who have seemingly the worst problems in the world, and small leverages can start changing that.
Well, the interesting thing here is that some CBT people who are trained to just slavishly follow the manual don't pick up on in-session characteristics of the patient that are highly, highly relevant because it's not in the manual. Focusing on what's going on between sessions becomes the eventual goal for change rather than what's going on in the session. So if a patient says about their partner, they say something like, yeah, he is just, that's the way he is. And they have that clear tone of voice of annoyance. And you pick up on that as a therapist, regardless of your orientation. It gives you a clue that maybe that's the way this person interacts with his partner or her partner.
Marvin, you just read my mind, because the next point I was going to bring up was transference and countertransference.
Okay.
And
I would never try to read your mind. I think it would be.
It's an open book, Marvin.
How about that? Our next podcast, huh?
I'm one of the simplest people you've ever met.
Oh, no. I'd find out.
It's all common sense. But I think you were perfectly anticipating the point that.
Yeah, but I'd have to put on protective gear if I were reading your mind. I'm sorry, go ahead.
The idea of transference, which one of the main contributions Freud made when he realized that patients who had repetitive patterns would have those same repetitive patterns in the treatment. And that the interpersonal styles of relating and feeling things, seeing things, wouldn't stop when they walked in the door, that they would feel the same thing towards the therapist and act in similar ways. And that this was an enormously useful tool. You could understand right before your very eyes what the patient was describing in real terms, because you'd be seeing it happening in front of you. Mm-hmm. It was a tool not just for understanding the person better, but also if you could work with the transference to have the relationship between you and the patient change and hopefully become healthier, that would be the corrective emotional experience that would help to carry into other relationships what they learned in the relationship with the therapist.
Right. But now you're not talking Freud anymore, because when you use the corrective emotional experience, you've left Freud, as far as my understanding of Freud. My understanding, and correct me if I'm wrong, because you're the psychodynamic maven in this duo, that the focus on the transference is to resolve an unresolved conflict, as opposed to pointing out a maladaptive pattern.
It's really both. And the idea of the corrective emotional experience came out of the work of Ferenczi and his students, Alexander and French, and they were really building on the concepts. I don't think we have to worry about parceling credit to this guy or that guy, but the idea very much was that the transference was transformative. The interpretations.
So here's the problem. I just learned something from you. I didn't know that Alexander and French had their roots with Ferenczi.
Ferenczi was the analyst for Alexander.
Right. So, because that's not in the textbooks. So when we read about psychoanalysis, we read about Freud, and we have a misconception of what psychoanalysis might really be.
Yeah.
So
I think it was inherent even in the work he was doing that there would be a corrective emotional experience by pointing out the transference aspects in the treatment, and that would carry over to outside. And Ferenczi was actually a much better therapist. So Freud was in it for the research aspects of it. He always made clear that he was never that interested in curing people. Ferenczi was the great therapist, and Ferenczi's students made the greatest contributions to psychotherapy technique.
I think you just put your finger on something that has created a lot of misconception and problems in understanding psychoanalytic therapy. Namely, that you said Freud was less interested in therapy and more interested in building, I think, a theory of personality. And that's where the difficulty arises, because the unconscious and all this other is the store place, and talking about how personality develops and how it shows itself as an inference from people lying on a couch and talking about their problems is kind of weird, to make that jump and talk about people in general. So I think the fact that he had bigger fish to fry pushed him in a direction that really, other people picked up on the more therapeutic kind of thing.
Other people picked up on what was more experience close
in session.
More involved in trying to take the experience close and make it into a theory that would be more experience distant.
Exactly. One of the books I read that as a graduate student that was very, very helpful and continues to be helpful in my understanding was Wilhelm Reich's Character Analysis.
That's a great book.
That was before he did orgone therapy. And basically, he pointed to observations within the session. So he was very much as you like to put it, following the patient.
Right. And related to transference is countertransference, which is very often misunderstood and abused. Countertransference would be the equivalent in the therapist of what the patient's experiencing with transference. And it divides into two kinds of experiences. They're really quite different and shouldn't be confused. Mm-hmm. One is the irrational aspects of the therapist's reaction to the patient based on the therapist's own personal experience, own attitudes, own emotional baggage. The way the therapist may distort what he or she is hearing from the patient based on their own personality and experiences would be one way of understanding the therapist's reactions. But we should also realize that the therapist's reactions are partly due to a realistic reaction to the patient's behavior. So we have to divide out the therapist's unrealistic views of the patient based on biases from their realistic view of the patient. Right. And the reason this distinction is so important is that countertransference can be of enormous informational value to the therapist to the degree the therapist understands themselves well.
Right.
If you can tease out as a therapist those things where you tend to have biases from those things that are realistic reactions to the patient, it provides tremendous informational value because you can begin to understand how people respond to the patient in real life.
Right. I mean, there are a number of important issues, and certainly this is not within CBT, except Jerry Davison and I wrote about this in 1976 in our book, Clinical Behavior Therapy. But of course, I was contaminated by psychodynamic therapy, so I put that in.
I would say enriched by rather than contaminated by, but okay.
Enriched. I'll stand corrected. Brainwashed. No, enriched. You're right. It's like, why am I reacting this way? One of my cues as a therapist is when I feel my back pushing into the back of my chair. That's a marker for me to raise the question, is the patient doing anything to make me have this reaction? And is this a sample of that person's problematic interpersonal behavior?
There you go.
Right.
There you go.
And you well know that the CBT person who addressed this issue, although it wasn't called countertransference, was Marsha Linehan, working with people who could really annoy the therapist and frustrate the therapist. And she recognized that was anti-therapeutic.
And the most valuable thing, amongst many valuable contributions I think she made, was to help therapists feel comfortable with the angry feelings they would have towards patients who would be doing things that would normally make them angry, but instead of just reacting to it, having ways of dealing with their own feelings and dealing with the patient's behavior that would reverse the vicious cycle that the patients would tend to get into, both outside the therapy and within the therapy.
Right.
One other point.
Before we go off this, we can hark back to one of our very early podcasts. That is, I am a better person as a human being when I do therapy because I'm more accepting.
There you go. And more aware of how your reactions may be interfering with what's happening, whereas in everyday life, we tend to react and just go along with it.
Right.
In therapy, you reflect on how you're reacting, and you're able to smooth some of the rough edges that come from your own experience that really aren't pertinent to helping the patient, which is
Right.
what we're there for.
How to be in therapy without being in therapy.
Now, there's one mistake that's often made by psychodynamic therapists, and I think by other therapists as well, without always being aware of it.
What is that?
That's to assume that patient's behavior is always transferential, not a reaction to what the therapist is doing.
Yeah.
So most common, and I won't name names here, but some people may identify themselves. The most common thing is the therapist does something that's infuriating to the patient. The patient gets angry. The therapist then says, aha, you're angry at me because of your transference. Not recognizing that his or her own behavior may have triggered the anger, triggered the disappointment, triggered whatever it is that the patient's feeling.
Yeah.
That it's very easy to blame the patient, blame the victim in a way, attributing all of their negative feelings toward the therapist to their transference and sort of taking the therapist off the hook. It can't possibly be my behavior. And I think it's very important that therapists not use transference as a kind of disguise or mask to always put the blame on difficulties in the treatment onto the patients. And one of the great things cognitive therapy has done is to have the therapist be very conscious that the evaluation of the patient can be rational. How am I doing? How are we doing? What could be different? To respect patients' attitudes and negative feelings when they're negative is not always being due to transference. And where the mistake in psychodynamic therapists make is often to see everything through the prism of transference.
That's, the more generic problem there, I think, is the therapist doing something in therapy as a function of their theory rather than what's going on.
And also using the theory as a shield to not recognize your own mistakes, your own inadequacies, your own uncertainties, your own contribution to trouble in therapy when it's happening. So the first thing I think a therapist should always think of when a patient's unhappy is what's not working in the therapy on a realistic level before assuming that the patient's unhappiness or disappointment or anger is necessarily and always due to their transference reactions. That's always irrational, because very often patients are disappointed or angry because we're just not doing a very good job or because their life situation is very difficult. It doesn't necessarily have to be a specific transference repetition of problems in their past. Okay, the ninth thing on my list is that psychodynamic techniques are often necessary, I think, for every therapist. So just as you were enriched by psychodynamic techniques, I would hope that every therapist would be enriched by psychodynamic techniques. However, they're often not sufficient, especially when people present with more symptomatic problems. And we have to recognize that there's nothing inherently in opposition between psychodynamic techniques and cognitive techniques, behavioral techniques, interpersonal techniques, paradoxical techniques, that it's possible for a clinician, and I think desirable and almost necessary for a clinician, to understand and use the psychodynamic approach that we're discussing at the same time that they're fully cognizant of behavioral techniques, cognitive techniques, interpersonal techniques. And
here, I think I might be disagreeing with you, but it may be just semantic. You're talking about techniques, and everything that you've been saying up until now has been more concepts rather than techniques. So when you talk in concepts, it's like, sometimes the pattern of behavior is occurring within the session. That's a concept. The technique is what the therapist may say or do, and that can vary from therapy to therapy. So I think that's where we break down the similarity, when we get too much into the specifics of what is being done rather than why it's being done.
Yeah, in other words, it may be that a psychodynamic therapist might be more inclined towards providing insights, interpretations of the behavior, and hoping that these will help to reverse the vicious cycle. Those insights might be more related to past patterns of behavior. Cognitive therapists might focus on exploring the current situation and the thoughts that are leading to troubles more than the past. A behavior therapist might be more inclined to behavioral homework, that there might be different techniques, even with a similar understanding of, of the situation. And I guess what I'm saying is that I don't trust therapists who only have one toolkit.
No, I agree that techniques are important, but if we're looking for similarities across orientation, I think we're better off dealing with the conceptual level, not a high level of theory, but a conceptual level. Like sometimes the patient is without being aware, is bringing about their own misery by how they interact with others. Okay. So I see that as a concept. And then the therapist it would be helpful if the therapist got the person to become aware of this. Again, there's no technique involved of how it's being done, but it's a procedural process or principle and process.
Yeah. I think the 10th thing I was going to bring out is that some treatments are geared toward change and other treatments are geared toward support. And I think that there's been far too much emphasis in the psychodynamic literature, as well as in the cognitive and behavioral, on helping people to change their behaviors, and far too little emphasis in supporting people who don't have either the desire or the ability to change their behaviors very much, and just need help in stabilizing a situation that needs to be stabilized. So supportive therapy can use techniques derived and theories derived from all the different types of therapies, just as change therapies can. Supportive therapies are vitally important, that support is an important part probably of every therapy, and that we need to be thinking not just in terms of helping people to change, we need to be thinking about those people who really just need to be helped to stay where they are, because that's often the struggle.
Well, it's interesting. What comes to mind to me is the Menninger research. I haven't seen it cited very much, but it did exist, where the Menninger Foundation compared supportive with insight-oriented and found that both were comparable in effectiveness. Yeah. And then the findings were buried.
Yeah. And I think that the people who deal with basically healthy patients who have discrete problems in the context of a life that's going pretty well, and those therapists can include psychodynamic therapists, cognitive therapists, behavior therapists, interpersonal therapists, family therapists. If you're dealing with a fairly healthy population, you get the idea, because of your experiences, that most people are in therapy to change their behavior and make for a better life and understand themselves better and to change their relationships. But if you've dealt with that sicker population, most of my career was dealing with sicker patients, people who were experiencing medical illness. If you have a heart attack, at that point, you're not going to change your personality. The question is, how can we help you get through this heart attack? And if you have obsessive traits, we're not going to try to change those obsessive traits. We're trying to use them supportively, help you get control over the situation as much as possible. If you're dependent, we're not going to, during the context of a heart attack, try to make you less dependent. We're going to give you advice and support, and you're not going to be expected to make decisions for yourself as the obsessive patient would. That the supportive techniques use the understanding we have of personality to help support the person through the acute situation. People who have chronic psychiatric illness very often we're not trying to help someone who has schizophrenia or bipolar disorder make radical changes in their personalities or their reactions to life. We're trying to help them get through the day, to figure out what goals are realizable. And that a good part of therapy, the therapists who say never give advice have never treated sick patients who often need advice.
Absolutely.
We have to have a balance between the idea that every patient who comes in is going to bloom and be very much different than what they are today because we do therapy for change. We have to have the idea that for many patients, we have to help them get through the day, through the month, and that support is a very important part of probably all.
This is a common theme we've been talking about. That is, follow the patient, not the theory. Don't try to squeeze the patient into a theoretical orientation. That's a poor fit. Okay, we need to stop, but I just had a thought. If somebody listening to this podcast would take these 10 concepts, it would be nice to have a survey done to see whether or not more than just the two of us agree that this is a common foundation of therapy. Be easy enough to do. They just have to go back and transcribe the last 2 podcasts, current and previous podcasts, and send out a survey. And I would bet anything you'd get very high agreement.
So the question is, how do we get the field, not individuals describing themselves in the survey, how do we get to training programs so that they try not to be focused just on teaching DBT or cognitive therapy or behavior therapy, that they try to be more ecumenical and follow the patient with whatever the available understanding and technique that most applies to them at this moment?
Well, one way is to have a survey. The other way, and there are more than just 2, is to have regular podcasts. So hopefully we can have some impact. Good talking to you, Alan.
Okay,
have a good day.
Always a pleasure,
Stay
Marvin.
safe.
Bye-bye.
Bye-bye.